Please.
Okay, thank you very much. So my only disclosure, if I could just have the next slide, thank you, is that as all the speakers have demonstrated at this meeting, is that what you need is to work closely with the ophthalmologists. They're by and large extremely nice people, and they are very much part of a sort of symbiosis. So you help them, they help you, and it's been a wonderful experience for me to be the ENT consultant for Moorfields Eye Hospital, which is the postgraduate eye hospital in the UK, and is just down the road from my hospital, the Royal National Throat, Nose and Ear Hospital. So what I'm going to talk about is something that is really, really, really rare, but it's worth flagging it up because what's quite consistent in the history of all these patients is that they are frequently missed when they do occur. So you can see up till 2010 there are only 700 cases in the literature, and what I'm going to concentrate on is the more common ones, which are the transitional papillomas or carcinomas, the occasional cylindric carcinoma and squamous cell carcinomas. But if you look in the literature at the range of pathology, just as in the nose, you can find just about any sort of tumour, and indeed it is possible to find melanomas, mucoepidermoids, lymphomas, etc. So once again, you need expert pathology. The issue has often been discussed, certainly in relation to inverted papilloma, as to how important HPV might be. And we set about looking for these in our own cases. We looked at, as you can see here, 16 patients, 10 transitional cell papillomas, 5 carcinomas, 1 squame, and a control group. It was sort of rather underwhelming, I'm afraid. We did find a little bit of positivity, but it was only, as you can see, one case in the TCPs, 2 of the 5 carcinomas, and the controls and the squames were negative. So it's a very tiny study, but at the moment, I think the jury is out. How do they present? Well, they present like a lot of patients do, with unilateral watering of the eye or repeated infections. But sometimes they do actually end up with a dacrocele or actual mass, and they may have a visible mass at the canaliculus. And sometimes when you look in the nose, you may be fortunate to actually see a mass of papilloma, but that is rather the exception. And that is because the majority of these patients, nobody suspects that it's a tumour because they are so rare, and they are found at a DCR. Or they're found at the revision DCR when the first DCR didn't work, or the DCR after that. In other words, many of these patients have DCRs done, and even then, the ophthalmologists, because they're not usually using endoscopes, don't see the papilloma or the cancer. So here's a couple of examples. You see on the edge of the rhinostomy here, coming out, a papilloma. So many of these patients will have had DCGs. They may have had a CT done, but the ophthalmologists tend to do them in the axial plane, so that doesn't always give you a very good answer. I don't know that an MRI is really necessary, but the most important thing, obviously, is somebody takes some tissue. Now, an informed ophthalmologist or one who's dealing with a revision case may see the tissue and take it, or indeed they may ask you to see the patient, in which case you can do the biopsy endonasally. I've got 36 patients with tumours in this area, which is a tiny number, but actually one of the largest series there is. And you can see the breakdown here: 12 papilloma, 10 TCCs, 3 cylindric cell, and 11 squames arising within the lacrimal sac. Interestingly, women are slightly more commonly affected, though statistically all the figures are going to be slightly wobbly because of the overall numbers. But you can see here that it tends to be a disease of the group of people who are coming with epiphora for other reasons, and that's another reason why they get missed. Can you pick them up on imaging? Well, you can if you're sort of thinking about it. I mean, that would easily be missed for a dacrocele. The thing about it is it's smooth. It's the bone is ending abruptly here. There's no suggestion of infiltration. So, you know, odds on it's likely to be something benign. Whereas this case, where we've got a transitional cell carcinoma, you sort of see there's a little bit more moth-eaten change in the bone adjacent. But it's a very subtle change. You can't make the diagnosis based on the imaging. All you can say is that there's something going on in that nasolacrimal sac. Squamous cell carcinoma, bit more straightforward in the sense that there's likely to be more destruction, and even if it's centered on the duct, obviously we're seeing here infiltration into the soft tissues, and of course that may be better demonstrated on an MRI. So what are we going to do? Well, it's reasonably straightforward. If you have a transitional cell papilloma, the treatment at the present time is surgery. If you have a patient with a cylindric cell or transitional cell carcinoma, surgery is the primary modality, and you may choose to discuss radiotherapy with the patient depending on the confidence of your resection. Of course, with the squamous cell carcinoma, they will all receive surgery and radiotherapy, and then you're going to have a discussion about whether adjuvant chemotherapy might be part of the protocol of the place you work in. But what you do have to do is remove it in its entirety. And therefore, in my practice, I do a complete excision of the entire nasolacrimal system. So that may include the previous DCR incision, an endoscopic clearance of at least the anterior ethmoids, the medial maxilla, and up to and including the lacrimal fossa, and the whole nasolacrimal duct, which I always put a stitch on to get the pathologist to see where the end is, so they can look for seeding down that nasolacrimal duct. Because whether or not we can prove there's a virus going on here, the fact is that you do see these multiple sites. And if the tumour has gone through the sac and is adjacent to the periosteum, just take away the periosteum. It's the simplest thing to do. And then you can I like to use a skin graft. Why? Because a skin graft contracts. So you can take away the whole of the periosteum of the medial wall if you want to. You slap on a skin graft, it takes beautifully. Okay, it's not a mucociliary mucosa, but it contracts and it will offset any enophthalmos that you might get. So I think it's a really easy tool, but you can use nasal mucosa, say from the opposite side of the nose from a turbinate. Now, if the tumour has gone through the periosteum and is actually infiltrating the fat and or muscle, if the patient is curable, which they almost always are in these cases, I think you do have to be cruel to be kind. And these patients are offered an orbital clearance, particularly with a squamous cell carcinoma. So that has occurred in 6 of the patients. So if we look at the results here, I've put here LRC. So it's we can call it a lateral rhinotomy because we are opening the side of the nose. We're using extension of the little DCR incision that's often there, excising the edges of that. But as Darling's very nicely shown, you know, it's not all or one. We can combine these techniques all the time. We can always look with our endoscopes through the external incisions, through the nose. It gives us fabulous visualization. So I most often go from the front because I'm right at the front with this tumour. I never feel that confident just coming from within the nose when I'm sort of coming back on myself. But there have been 4 cases where I was able to do the resection just by an endoscopic route. Cylindric cell carcinomas, most of them have had external lateral rhinotomy, as you can see here, and or removal of the orbit, and 6 of those have gone on to have radiotherapy. The cylindric cells, there's only 3 of them. Again, lateral rhinotomy and orbital exenteration, 1 receiving radiotherapy, and in the squame group, again, lateral rhinotomy plus minus endoscopic, 4 orbits and 9 with radiotherapy. Now, overall, I've got very long follow-up on most of these patients. I've excluded the most recent one, which was in the last 6 months. And you can see we've got years and years of follow-up in most of them. Overall, the TCPs can be cured. I've got 2 that have behaved very aggressively, one of which is now, at the moment, free of disease, but one who still has recurrence in the nose. The cylindric cell carcinomas can also be cured by and large, but sadly 1 patient died of disease. The cylindric cells, well, there's only 3 of them, but 1 died. And again, with the squames, we've got 8 alive and 3 at risk. Of course, the poor patient comes with a watery eye. By goodness, they go away with a watery eye because you've taken out the whole nasolacrimal system. Interestingly, of course, if they have some radiotherapy to the area, even though they're protecting the gland, it does seem to be less of an issue afterwards. But we do have to resort to some sort of tube, and I liked the little tube that Sal showed with the grommet end to it, because actually, although we put these in, they're a bloody nuisance. I mean, they're forever popping out here. The patient can't find them. They can't put them back in. So in theory, they're a nice idea, but in practice, if you can, leave a large opening in the medial canthal area that will connect into the nose, so they've got a natural opening. Double vision is very rare. You can take away a lot of periosteum, you will not end up with double vision. And if you do have to take the eye, obviously we have osseointegrated options now for these patients. So, if we look at the outcomes, the median follow-up is 12 years. I've had 2 patients with the papillomas come back, 1 of whom still has recurrence. 5 of the malignancies have had recurrence, that's 20%. The survival overall at 5 years for the malignant tumours, disease-free survival just under 80%. Recurrence, usually within 2 years, means residual disease. I didn't manage to get it out. Follow-up for 5 years for the benign papillomas, but as always, lifelong for the malignancies. And that's done with endoscopy and regular MRI. It is possible to get metastatic disease from these tumours, but it's really rather rare. So I don't normally stage or follow them up with any sort of PET scanning unless there's some specific problem. But this is the problem with these papillomas, and that is that they are multifocal. So when you look in the nose, you see multiple little papillomas growing all over the place in some of these patients. And so this can be quite a problem. You can remove them endoscopically, you can laser them, but as I say, I've certainly got 2 patients where they have been quite troublesome. So what can you do about that? Well, there's quite a literature on papillomas elsewhere in the body, and notably in the lower respiratory tract. I don't personally have any expertise, although I have used mitomycin in other situations, but I haven't used it for this. And you might argue that I'm shutting the door after the horse has bolted, but I do ask the patients if they'd like to get their GPs. In this country, the GPs can give girls Gardasil against HPV for cervical cancer prophylaxis. There's a big row going on about whether boys should have it. I think personally they should, but the GPs will give the Gardasil to adults if they pay for it. And so it's completely off the wall. There's no science to it, but at least half of the patients with the transitional cell papillomas have had Gardasil now, and I sort of feel, well, why not? There's no harm to it. So if we look at the malignant tumours in the literature, the ophthalmic literature, it's terrible. I mean, 50 to 100% of patients are dying. You think, well, why is that? We actually look what they're doing. I mean, I love my ophthalmology colleagues, but let's just say they went into ophthalmology for certain reasons. And some of it was to do with not doing big operations and having a lot of blood. And so they don't do big operations generally, and that in the past, for these sort of tumours. They would just curette it out Well, curetting out doesn't unfortunately cure it. And so in this study that comes from ophthalmologists, you see back in the 1980s showing that if you did a wide field resection, you had a recurrence rate of 12.5% as compared to local resection with a 43%. So I think that the message is, you know, we can do this. We can remove the whole system right the way down into the inferior meatus. And if you do that, okay, you're not going to get 100%, but you are going to get nearly 80% 5-year survival and a recurrence rate that you can deal with. So I think the jury's still out on this issue, but we're pursuing that a little bit more. And the reason for talking about it is that now, as we know, many DCRs are done endoscopically, and then many of them are done by ENT surgeons with an interest in the nose. So I think have a low threshold of suspicion. And if you open the sac, as Sal showed you at the beginning, you will see the entire contents and you will be able to institute early and radical treatment. Thank you very much.